All right, fantastic talk, Dr. Gill. Thank you so much. Let's redo your poll now and see if everybody learned something from that fantastic talk. So which of the following surface markers is specific to malignant myeloid cells? Select one of the following: CD33, CD123, CLL1, NKG2D ligands, or none of the above. Okay, great. So the answer here is none of the above, E. So one of the first questions, obviously the cases that you shared there were really fascinating, and the therapeutic index of having these CAR Ts proliferate definitely is a narrow window. You want it to proliferate, but not too much, as in your other examples. Has there been any possibility of capitalizing on things like the CLL TET2 example in the design of CAR Ts?
So I'm sorry, Jane, capitalizing on this, on the Collect12A, the CLL1?
No, in the CLL case example where you have the TET2 mutant T cells really helping with proliferation for that CAR T, could that potentially ever be considered in the design?
Yes. So that's a great question, and it is an area of active investigation at our institution. My colleague Joe Ferreira, who published that case report on the CLL patient, is working on that. I think the reason I put that together, those two cases, the JAK2 case, the TET2 case together in this presentation, is to really get us thinking as MDS myeloid malignancy doctors about the potential implication of what we always think of as stem cell or myeloid compartment mutations, the potential implication of those for T cells when we're using T cells as a therapeutic product. It's been really interesting trying to nail down some of the mechanisms in for example, in the CLL case, and then in the MPN case. So yes, personally, I'm very interested in capitalizing upon what those let's say inherited. I don't mean in a germline sense. I mean inherited by T cells from the somatic precursors. Their inherited properties, and what can we do to capitalize upon those and give us a better T cell product.
Great, thanks. We have a question from Dr. Sadiq Kasim. Do you envision also knocking out CD123 from hematopoietic stem and progenitor cells as well?
I think it's possible to do that, but the reason we started off with CD33 is its role was not clear. In fact, I think it's still unclear. It may well be redundant. CD123 I do expect to be non-redundant, at least in some cases, because it does function. It has a very clear function as the alpha chain of the interleukin-3 receptor. And interleukin-3 has a considerable history. We don't, of course, use it therapeutically now, but it was investigated in the 90s as one of the cytokines that were at the time being considered as a hematopoietic growth factor, as eventually we used GM-CSF and particularly G-CSF. So it is unlikely to be completely benign to knock out CD123 completely, but there are other approaches that we're investigating that may allow us to sort of thread the needle, as it were, and allow us to use CART123 cells without inducing complete myeloablation.
Great. Dr. Katerina Gotze asks, do you see a future in myeloid disease for BiTE or for CAR T, given that BiTE is available much faster?
Yes. So just like in, look, I think just like in ALL, and this is partly why I entitled this presentation, what we can learn from lymphoid malignancies is that, certainly plenty of experience with blinatumomab, plenty of experience, maybe a little less, but with CAR-19, particularly in children, I would say. What do we know? Well, the BiTE, so blinatumomab, is I think works exceptionally well in the MRD positive setting and not exceptionally well in the active disease setting. And CAR T cells in ALL work exceptionally well in any setting if we put aside for the moment toxicity, which I think is manageable. So while I think we have too few data points as yet, of course, there's the BCMA CARs and BCMA BiTEs also being investigated. So, but nonetheless, I think at the end of 2020, we have too few data points to really conclude. But what I think, Katerina, is that the CAR T cells are going to be more active, and for patients, and their role probably will be in patients with active disease, with a lot of disease, whereas the BiTEs will be better for, if you like, mopping up residual disease, which of course is a very, very important ability to do. Having said that, I completely agree. It is so much easier to prescribe and give bispecifics than a personalized product. And that observation then often leads to a second question, a follow-up question: what about off-the-shelf or allogeneic CAR T cells, or perhaps other cell types? And that is even further away from us in the myeloid space, but is, as the audience probably knows, is being actively investigated in the B cell space at the moment.
Great. So kind of a follow-up to that, how far off do you think we are in terms of seeing more MDS patients? The numbers are pretty sad. Thank you for collating those for us. But how far off do you think it is that we'll be seeing more MDS patients being treated with CAR Ts?
Yeah, so there are a number of trials all around the world, particularly in China, that are allowing MDS patients. I'm aware of one trial in the US that allows MDS and has treated some MDS patients. It's difficult. I think that as you said, Jane, the therapeutic window has been a little tight for comfort in AML so far, and so we'll have to do some work on that. But in my mind, there's no reason why we cannot treat MDS patients with CAR T cells. They are sort of like our discussion earlier about the combination of Vidaza and venetoclax in those patients with advanced MDS who are eligible and perhaps where we think it'll be feasible, a bridged transplant. I very much think of CAR T cells as a bridged transplant in patients with MDS who perhaps haven't responded to demethylating agents or to a combination thereof. That of course is yet to be studied. That has not been studied, just to be clear, but that's where I think the role of CAR T cells might be in that setting, unless we can come up with a way to specifically target the malignant cells, and that's why I made it the question, the multiple choice question for the audience, and that's why I spent quite a bit of time talking about that during my presentation. Is that I really don't think that we have a malignant myeloid specific surface antigen that can be used in CAR T cells, and so if we were able to find one or devise one, and I showed one approach where we could do that, then that really opens up the field quite a bit.
An excellent question also then is a cancer-specific antigen actually required for CAR Ts to work?
Well, it is not, because CD19 is not a cancer-specific antigen, and look what we can do with CAR-19 in lymphoma and ALL. It's a question of how tolerable is the off-target effect, and if it is abolition of all myeloid cells. It doesn't even have to be the stem cells. I mean, if you eradicate everything downstream of the myeloid progenitor, you're still not going to have differentiated neutrophils and monocytes. And if you believe that the CAR T cell, the immunosurveillance, if you like, needs to be persistent, for several months, then it's it's not impossible. We've all treated patients like that and successfully with a lot of supportive care got them through months of aplasia, but of course that's difficult. So ideally, and I think this needs to be a strong area of research, and ideally we would be able to find a cancer-specific antigen. Now to put this in context, of course, when you're dealing not with CAR T cells, but working with perhaps TCR transgenic cells, whereby you use the TCR and by its interaction with MHC class 1 or 2 and intracellular antigens, it is then possible to start talking about leukemia-specific or MDS-specific engineered cells. However, there are many problems with that approach. Firstly, it becomes a much more narrow proposition because you have to find the right HLA type. For example, HLA-A0201 is said to be the most common in Caucasians. Well, it's not that common. It's about 30%. And so that it just becomes more difficult, but it does allow you though to be very, very specific. And so I think that's another way forward there.
All right, great. Well, that is all the time that we have. Thank you very much for all of the answers to the questions from the audience and for your excellent presentation. So we're now going to continue on to our last presentation today. Dr. Stéphane Desbotans is going to be talking about targeted therapies in MDS. And we'll have his poll question coming up here. So in order to answer this question, we'll first have the case presentation. So this is a 72-year-old man with newly diagnosed MDS with excess blast 2. He presented with a 4-week history of fatigue, has an ECOG performance status of 1, remarkably has no past medical history at his age. He has a white count of 1.8 times 10 to the third per microliter, a hemoglobin of 7.8 grams per deciliter, platelets of 15 times 10 to the 3 per microliter. The differential shows 8% blasts, 19% neutrophils, and the bone marrow aspirate has 30% cellularity and 17% blasts. A diagnosis of MDS with excess blast 2 is established, and the molecular data show a TP53 mutation. The karyotype is 46XY. So in your current practice with this patient, which treatment would you recommend? Select one of the following: 7+3, 7+3 plus gemtuzumab ozogamicin, CPX-351, 10 days of decitabine, or venetoclax plus azacitidine. Okay, great. So we'll take that poll again after the presentation. We'll continue on with Dr. Desbotans' presentation.